Thank you very much, Michelle, ladies and gentlemen. As a matter of clarity, we separated two topics concerning cystic tumors of the pancreas, and in the following talk I'm going to speak exclusively on serous and on serous cyst adenoma and mucinous cystic neoplasm. And to start with it, I want to address a keynote paper published by the Boston Group looking at 851 resections. And there were 137 serous cyst adenomas and 199 mucinous cystic neoplasms. And it is quite clear that in the group of serous cyst adenoma, there was not a single malignancy being found. On the other hand, the mucinous cystic neoplasms turned out to be malignant in about 10% of cases. So we can clearly confirm by these data that the mucinous cystic neoplasm is a potentially precancerous lesion. So when do we operate? If there are symptoms, yes, there should be an operation. This is very clear and this is not debated. But if there are no symptoms, these are incidentalomas in 50%. If there is a serous cystic adenoma, there should be no operation. And the challenge is that the differentiation is not 100% possible, and we can only look at profiles of probability. So the group of Go from Singapore, they came up with three parameters: elevated serum tumor markers, the size above 3 centimeters, and suspicious morphologic findings in CT and MRI, suggesting that this is a dangerous lesion. And they could show that there's a positive predictive value. If one factor is present of 74%, it increases with 3 factors up to 90%. But in fact, it is not 100%. And this is the challenge to all of us. Dr. Warshaw's group did research over many years in the CEA in cyst fluid. And they described a cutoff of the CEA in the cyst fluid at 192, and you see that sensitivity and specificity is optimal at this value. Now they added ultrasonography, morphology, endoscopic sonography, then cytology. And you see that accuracy of CEA cyst fluid content is best with 79%. And most interestingly, if you combine more parameters to the CEA cyst, you do not increase accuracy beyond CEA alone. And I think this is a very good parameter to rely on if necessary. So we all agree that malignancy must be avoided. So basically, the indication to operation should be broad. But the prerequisite for this concept is that there is high quality of surgery. Now, concerning our own numbers, you see that these are not vast numbers concerning cystic tumors. 27 is not very high. And so if we are dealing in that setting of pancreatic surgery, this topic has to be embedded into a functioning, high-quality program of pancreatic surgery. And you see, if we look at 415 resections at our institution, we end up with a mortality 30 days 1.6% and total 2.9%. So this is a prerequisite that concepts I'm outlining to you now work, even though you don't treat high numbers of cystic tumors. Now, the special aspects of cystic tumors, surgically speaking, are that mortality is extremely low, 0.5% to 0.7%, and I picked out two leading publications of the Boston Group and of Brennan in New York, and you see there are high numbers of patients, 850 and 422, and this really holds true: low mortality, but still high morbidity. But does that really affect our decision? To a low degree, because you see that over the years, and Dr. Warshaw described that, over the years, the hospital stay, length of hospital stay decreased steadily now concerning the Whipple resection down to 7 days. And if you have a 7-day hospital length of stay, morbidity cannot be so profound. How to operate? There is generally the concept is determined by the localization of the cystic tumor. That is clear. But there are, in fact, possibilities, approaches to do local surgery. We have a local segmental resection here, which is done repeatedly with great success. And I'm going into that more. I just want to show you how we do the reconstruction in Rostock after a middle pancreatectomy. We have a pancreatic head here with interrupted sutures, PDS 40, to close the head. And here is the pancreatojejunostomy in invagination technique. And this is a very clear-cut situation. Now, Beger, he advocated that his duodenum-preserving pancreatic head resection could be applied in cystic tumors with success, and he even draw a sketch in one of his publications showing the confined resection of the uncinate process with duodenal segmental resection here for treating cystic pancreatic tumors. The whole literature reflects that there are pancreatic head resections, duodenum preserving, in different centers described for that disease entity. Keith Lillemoe, he even went further and described enucleation for cystic tumors, 45, and he did a matched pair analysis with resection, and he came up with the interpretation that pancreatic fistula is comparable, but serious complications, as he called that, were decreased if enucleation was performed. But if you look into that publication in detail, you see that there's a similar length of ICU stay. The readmission rate is identical, and reoperation rate as well. So there is not really evidence that confined surgery to the extent of enucleation is doing something better as compared to other methods. So if I summarize at this stage when to operate, if there are no symptoms, there should be no operation in serous cystadenoma. In mucinous cystic neoplasm, since it is precancerous, in general there should be operative treatment. If there are no symptoms and the categorization is impossible, which is the case in a couple of patients, size matters. Below 3 centimeters without formation of nodules, there can be follow-up. It should be operated if size increases. If the tumor is above 3 centimeters, and especially if it has nodules, there should be an operation right away. If there are symptoms, if we have the symptomatic patients, there should always be an operation. Now finishing, I want to describe a short case report from our institution, a 73-year-old patient with that large cystic tumor in the head of the pancreas, and these are the transverse slices. You see that the duodenum is compressed. However, the patient was asymptomatic with a duct size of 6 by 8 centimeters, a large tumor with the following comorbidity: status post-coronary bypass, now recurrent stenosis on Cumarol and clopidogrel. So considerable comorbidity. And we decided to puncture the cyst, and the CEA was below 5. So we decided not to operate despite the cyst size. But we also asked the question what to do if duodenal obstruction should develop. And we already set up the strategy that we would then discuss a Couch-Whipple resection. But the individual decision in this patient could also be that we end up with a gastroenterostomy. And this exemplifies what we are talking about in the end. The individual profile of the patient matters, and the quality of surgery you are able to provide. And I want to thank you all for listening, and I'm finishing with that nice picture of Rostock during sunrise. Thank you very much.